Welcome to Mama Tusa, Conversations with a Midwife. I'm your host, Atusa Benji. A quick note before today's episode. This show talks about birth, life, death, and all the complexities in between. My goal is always to share stories that leave you feeling empowered, but please know that some topics may be challenging or deeply moving. Also, while I'm an experienced midwife, I'm not your midwife, and the information on this podcast is not intended to be medical advice. Please consult your healthcare provider when considering what is best for you as an individual. Now, without further ado, I hope you enjoy the show. Welcome to the Mama Tusa podcast. I'm so excited to have you. Dr. Nora Zaghi is my guest today. Welcome.
Thank you for having me.
Thank you for your time. I know you're busy practice and kids and life. I'm so grateful for you agreeing to be here because I have so many things I want to converse with you about, so many questions. And I know that so many of my clients have things that happen with breastfeeding and speech pathology and mouth and tongue and lips and all of those things. So I really want to talk to you today about pediatric dentistry. Dr. Nora Zaghi is a board certified pediatric dentist practicing in West Los Angeles. What's the name of your practice?
Breathe Kids.
Breathe Kids, love. And it'll be in the show notes. So
Yay.
viewers, you can find it in the show notes, all her information, how to get in touch with her. Let's dive right in. Why dentistry and why pediatric dentistry?
Ooh.
Kids hate dentists.
Great question. I mean, I think I dove into specifically pediatric dentistry because I was just good at it. So when I was in college, and since I was 15, actually, I did kids' birthday parties. So on the weekends, I was on Saturdays and Sundays and Friday evenings, I would go to people's homes or they would come to different places I would work and I would dress up in character costumes. Like, you know, the typical 2-year-old, 3-year-old, 4-year-old, 5-year-old birthday parties. And I would dress up and I would entertain and I was with the kids. And that was my happiest time, being with kids. So as I explored different fields, I found dentistry. I liked it. And then when I went into the field, I started working on adults and I was like, this is really weird. Mm-hmm. And I was like, they're so much older than me. I'm so young compared to them. And then when I was working with the kids, I'm like, oh, wow, this just like is so fluid. It makes so much sense. It just felt like it was meant to be. And pediatric dentistry is truly my passion. I think it's my purpose.
I love asking people that question because people end up in places that actually make complete sense when you look at the flow. But people come from such interesting places to the places that they're at and truly find their purpose. I love that story. What character did you, what character were you famous for?
A fairy.
You were a fairy. I love. But also kids are fun because one, you're teaching them hygiene and habits for the rest of their life. And two, I'm assuming that the average kid doesn't come in with major dental issues.
They do.
They do.
I mean, not the average, but I would say it's sad because we have pediatricians and other like healthcare professionals that don't advocate for seeing a pediatric dental provider early in life. They say maybe 2 or 3 or 4 is a good age to be seen. Mm-hmm. But unfortunately, I've had to treat kids as young as the age of 1, even in the operating room under general anesthesia for severe early childhood caries. And childhood caries is one of the top conditions of chronic diseases now in our lifetime. So
what is it?
What is the reason? Yeah. I think it's diet. Mm-hmm. I think it's education around supporting families with early information about oral hygiene. Mm-hmm. I think it's this fallacy that people think that teeth fall out so it doesn't matter and you get a second set. But people don't realize that our teeth are connected to our entire bodies and it can cause trauma. It could cause anxiety for your entirety of your life when you have these issues, and it can cause severe other related issues to your whole body that can affect your speech, your development, and your growth. So I hope that things will be on the up and up as we have social media and we have access to the internet and all the things that I didn't even have access to when I was growing up. So just getting the education, getting information out there, I think things will start to get better.
And so when do you like to see kids?
Ideally, it would be nice to see babies around the first month of life.
Wow.
And that would be to get information about the child's oral structure, to talk about very important topics like pacifier usage, bottle type usage, to have conversations about weaning off the pacifier, weaning off the bottle, when that happens, how to take care of your teeth once they come in, how to do oral hygiene at a really young age, what to use, what not to use. I think these conversations are important, but also developing the relationship early on in life. Because in my practice, I guess I'm a dentist, but really I'm a whole body focused dentist where I'm looking not only at the teeth, I'm really looking at everything from sleep, from breathing. I'm talking a lot to families about their milestones and what we might be missing and helping them be on the trajectory. So these conversations can be had just by developing a relationship early on in life and being aware of what is to come, especially for new parents.
So you're collaborating with the pediatricians.
I am.
A lot. You're doing a lot of probably the teaching that they don't get to do.
I'm learning with them through our patients. I mean, I think it's always a journey. As a provider, you agree. Every time you meet a family, I've been doing this for 10 years, and every time you meet a family, you learn from them.
Absolutely.
So we learn together. I collaborate with them. I also work a lot with, like you said, birth workers, ENTs. My husband's an ENT. I work with body workers. I work with chiropractors. I work with speech therapists, and I work a lot with OTs. I would say that those are the top fields I work with.
Love it.
Yeah.
I love it. It really takes a village.
It does.
It really does take a village. So walk me through a 1-month visit. Would that include just looking at the mouth or x-rays or what are you doing with a 1-month-old?
Good question. So when I see an infant, I'm really having conversations with them about what they're seeing and what they're feeling. So if a mother is breastfeeding, we're having conversations around how that's going and who they're working with. And I'm talking to them about bottle usage, pacifier usage. We're looking to see how the baby is moving their head. I'm asking questions about birth so that we can guide them along the way to having proper growth and development. I'm also looking at their oral structures. So we're looking to see what the oral function is like, how the tongue moves from side to side, how it lifts, how they suck and swallow. I'm looking at the lips, I'm looking at the cheeks, and I look at their nose, and I look at the back of their throat. And this is very helpful because we can help guide them to having good proper nasal breathing, which is really important. Good tongue posture, which is really important for their overall structure, and also good closed mouth posture.
It's all connected.
Yeah.
And so many times you see a baby who has had a vacuum delivery or has been in a breech position for 3 months or has had a long pushing. The parent was pushing for 5-6 hours. I mean, in our practice, usually we don't push for 5-6 hours at home. We're usually transferring by then. And typically it's okay, but we just need an extra set of hands in case, in case we need a vacuum or there's something else going on after the delivery. But we see a difference in those babies. And I often wonder, are the breastfeeding issues that we're seeing, I think it's multifaceted, obviously, but there's definitely something anatomical, physiological going on with the baby at that point from the development standpoint. But then there's the trauma of the birth that probably makes the baby a little more agitated. And then the agitated baby who's not feeding properly affects the mother
100%.
Who's like, what am I doing wrong? What's happening? Why is this so hard? And then you see this loop.
Yeah.
And I wish more people practice like you because it really is, it's so holistic and so many babies, we're seeing two things happen. One, parents are taking the kids more to the pediatric dentist for what's going on with the breastfeeding. But two, they're taking the babies to the pediatric GI for acid reflux for babies. So there's an influx of acid reflux medication being given to babies, which I sort of wonder about. But one of my favorite GI physicians, adore her, female in her, she's about my age. She's great. And she says, a lot of times, Atusa, they come to me, these babies are fussy. The mothers are out of sorts. I spent 1 hour with them. I listen to them about the delivery. I listen to them about their life. I hear them. And typically they end up not needing medication at all. It was the mother that really needed to be heard and be seen and be calmed and be told that she's doing everything right. And the babies actually respond to that. Yeah. So I think there's a whole cycle that is happening here. I don't think it's just one thing. Sometimes it's very obvious. Can you give me an example of a baby who's been in the breech position? What are you seeing?
Babies that have been in the breech position, we see different things. Some are still delivered vaginally, and some are delivered with C-section. Those that are unaware of what can take place throughout the birth, the mothers have a lot of trauma around that experience. And the mothers that have a lot of trauma around that experience, I feel, come into the healing process of becoming a mother a little bit differently. So as feeding comes about, and I have a biased perspective because I see a lot of these mothers when feeding's not going well, because that's why they're coming to see me.
Right.
So it's a
That's your
combination.
fishbowl.
Yeah. So it's a combination of many things. They're healing. They are healing from either a C-section delivery or a vaginal delivery that didn't go according to plan. And they are also having feeding struggles, and they have a lot of anxiety around those feeding struggles. I would say those babies carry a lot of tension compared to other babies that I see delivered a little bit more effortlessly. I put it that way.
Yeah.
And that's when support really matters. And the support from the greater birthing community really comes into play, meaning people that are able to support the baby's tension as well as the family's feeding needs, whether that's a choice to bottle feed or breastfeed, or if it's even in the cards for whatever reason. And I would say a lot of these mothers also kind of get written off, unfortunately, as things just being normal, or it's okay, it'll get better soon. And it doesn't. And these babies, typically those with like lip and tongue ties, carry a lot of tension in their whole bodies, because the lip and tongue, when it's deeply restrictive, it connects to the entire body, and that through a deep network called the fascia system. So when the fascia system is tight, what happens is we see this tension travel through the body. And with a difficult delivery on top of that, tension is carried even more. So in my practice, I support these babies through something called photobiomodulation.
Ooh, what's that?
Yeah, it's a type of light therapy. Okay. And the light therapy that I use is a medical grade light therapy. And I use it on, honestly, many, many babies, not just babies with these types of issues. Yeah. But it's really my favorite thing to do in my practice. I call it neuromodulation, because it's helping with neural and oral regulation and helping with allowing the tension to be released in adjunct with other types of care, including chiropractic care, craniosacral therapy, and osteopathy to help the baby release that tension to hopefully feed better. Because, and I know this isn't related to your question, but I think it's important.
It's all related.
Because these babies come in with tension, imagine you're eating with a really tight coat on, or you're eating with so much tension in your body. You're not going to go to a buffet and eat a lot. You're going to go to the buffet and you're going to eat a little bit, and then you're going to go home and rest. But if you're going to the buffet with like your joggers on and you're like all the room to grow, you're going to eat a lot more. So these babies are having difficulty getting full feeds, having inefficient feeds because they're tired or they're tight. And it's really nice to have another tool in my toolbox to work on the baby's tension through this photobiomodulation sequence that we've curated alongside the practices of other providers and mentors that I've worked with, to help relax the baby in a very minimally invasive way.
What kind of light is it?
So it's called a photon laser that I use, which is very, very different than the other lasers that I use for actual treatment for tongue and lip tie releases. And I focus it on the entire body, and more so in the mouth and in the areas of tension.
So it like releases?
It releases the tension.
And how long does it take?
It can vary. I spend anywhere from 5 to 15 minutes. Sometimes I spend longer. It just depends on what we can do.
Wow, I wonder if you could use it on the mom
I do. Yeah, we call that mama lays.
You do?
Yeah, so I've worked on adults, yes.
So you've worked on adults
yes,
too.
And
because the person who birthed the baby and the baby are a dyad.
Yes.
So if you're going to have a tense baby, you're going to have a tense mama.
Yeah.
So how great that you're addressing both.
If that conversation comes about and the family's willing, I'd love to. It's something that we do.
Wow, I love that so much.
Yeah.
So, and then you're working possibly with a lactation consultant or with OT or with osteopathy. The whole team
Absolutely.
is on it.
We see very incredible changes.
I'm sure.
Yeah.
Because so in midwifery, and this is where there's a gap in obstetrical practice, especially in the United States, where typically a person delivers and the thing that is said is, it was great. It was unremarkable. Thank God baby and mommy are fine. Right? Fine is a big word. Fine is a really big word. And by the time an obstetrician sees that family again, it's usually 6 weeks.
Yeah.
Sometimes some doctors are now seeing them at 2 weeks, which I love because a lot is happening by 2 weeks. But by 6 weeks, that mom has cried, sweated, bled, been frustrated, it wasn't figuring it out, possibly not coped, possibly hit a wall, and then shows up at the 6-week visit with a diaper bag and a baby. I'm fine. And then they're like, great, you look good. Your stitches look good. Do you need birth control if you need that? When was your last PAP? Talk to you later.
Yeah.
And there's such a gap in everything that we see. So in our practice in midwifery care, we see the clients so we stay for about 4 to 4 hours after the birth. We settle everyone in, all being well, mother and baby are great. We leave. Our phone is on because ultimately we'll get that call or that picture of, is it okay the baby's breathing like this? Look what just came out of me.
Yep.
Look at the baby's belly button. All those questions that we get. So we're still on call. 24 to 48 hours later, we go to see the family. And at that point, they're sort of like, what just happened?
Yep.
Right. They're just trying to find their way. Check mom, check baby, talk about breastfeeding, weigh the child, possibly do the newborn screen. We draw the blood from the baby's heel, send it to the state. At 5 days, when we come back, that is a big visit because by then, is the baby losing weight? Is the baby gaining weight? Is the mother eating? Has the mother showered? Does she feel supported? What's happening? More than anything, we're like the eyes and ears of the postpartum period. And that's where we're able to see things and then refer to people like you.
Yeah.
Because so many times they're like, I don't know, look, baby crazy all the time, but my mom told me it's normal. I don't like breastfeeding. I'm bleeding, but they tell me it's normal. They say that my nipples need toughening up, like it's normal. No, honey, it's not. Like, let's have a conversation, because so many times you can actually set someone free by referring them to someone who can help them with what's going on. Absolutely. Or giving the option of, do you know you don't actually have to breastfeed? That's an option. Oh, I know, but they say it's so good for the baby. Yes, but we have options here. You can breastfeed, you can bottle feed, you can do both. You can pump and feed, you can purely formula feed. With all of these options that sometimes there's such tunnel vision about, this is what I thought it had to look like and I'm going to make it happen, but there's no tools to get it there, and also no exit door to be like, I thought I did, but I don't, and I'm not going to hate myself for it. Baby is healthy and thriving. So I love that you're seeing families and actually having conversations and actually talking about the birth, because it's like, mother's healthy, baby's healthy. Dr. Neil Shaw talks about it. He's a very amazing obstetrician speaker on the East Coast. And he's like, healthy mommy, healthy baby. And then we drop the mic. What does that mean exactly? Yes, thank God everyone's alive. No one hemorrhaged to death. The baby's good. But there's still a lot of work to do, especially in that first 3 weeks.
Absolutely.
It's huge. If you like Mama Tusa, check out Actually Useful, a show about why the tech world is broken and what we can do to fix it. Each episode, hosts Ariel and AJ talk to some of the smartest people in tech who are trying to build a better internet. If you're angry at Uber for jacking up prices, can't believe Netflix kicked you off your ex's account, or don't understand why tech CEOs can act like shadow politicians, Actually Useful is the show for you. My favorite is their episode on AI. I learned a lot about the climate cost of ChatGPT and how this AI craze is more of a hype trend than a real advancement in tech. It's a big topic. So I appreciate the team for breaking it down for their listeners. Check it out every other Thursday, wherever you listen. So I usually refer to pediatric dentists, such as yourself, because when we do the initial newborn exam, which is usually within 2-3 hours of the birth, we don't really rush into it. Before we leave, we do it. And we check the mouth, we check the palate, we check the suck, and we like to have the baby latched on both breasts before we leave. Sometimes it's really obvious. That tongue tie is so profound. You see that classic heart shape in the tongue. They can't thrust their tongue out. Mom is like, every time they go on. Well, okay, this might be a tongue tie issue. Lip ties can also be pretty severe. Like the frenulum doesn't even stretch far enough to pull the lip. It's so tight on the bottom and on the top. So in our practice, we don't necessarily refer right away to a pediatric dentist if feeding is going well and the parent feels pretty comfortable. We do give the caveat of sometimes these issues can go on to become speech issues, speech impediments. Yes, and maybe no. What are the percentage of people, if you have such a statistic, of kids who have tongue tie and also end up needing speech therapy?
I don't have that statistic, to be honest with
you. And is there
There's one study that we did that my husband conducted where he looked at 348 of his own cases and he looked to see what measures improved after tongue tie alongside myofunctional therapy. Okay. And he looked to see at like clenching, grinding, speech treated at the age of 2 up to the age of 78.
Wow.
And looked at those percentages and saw a statistically significant association with improvements in those figures he was looking at. And he saw a lot of improvements, and that was a very important paper to help support those of us in the community that have been doing this type of work. But I don't have an exact percentage, no. But I would say I see patients at various ages later on in life if it goes undiagnosed or untreated after the age of, like, say, 6 months and on. Sometimes I see babies with difficulty clearing the spoon for spoon feeding with preloaded spoons because it's difficult to curl the lip, for example, with those lip ties, or it's difficult to seal the tongue and cup the tongue with those tongue ties, whether it's anterior or post or mid to posterior tongue tie. And then we see kids later on with like difficulty, for example, chewing and swallowing harder to chew foods in different textures. So feeding might become an issue. And then later on, we might see issues with the child closing their lips because of the tethered lip or because of the low tongue posture.
Right.
And that can lead to a lot of difficulties with drooling and pooling of the saliva. Right. And then I also see kiddos later on with difficulty with but, p, and m sounds sometimes when it comes to lip ties. O and oo sounds. And then later and we also see issues with t, d, l, and na because you're using the tip of the tongue.
Tip of the tongue, yeah.
And k and g related sounds in the rolling of R's and connecting those sounds when we have the mid-posterior tongue ties. So we'll see these issues anywhere in life. And then also potentially a lot of crowding and small jaws because the tongue is staying low, because nobody really thinks how important the tongue is in the growth and development of your mouth, because the tongue acts as a natural retainer. And keep in mind, I didn't even learn this until residency. And I was treating kids with like orthodontic treatments and all sorts of things. And then it clicked, like, why are some kids so different than others? And I started to look at oral posture, whether it was due to a tongue tie, whether it was due to like nasal obstruction and other issues, and why the tongue kept staying low and what came of it. So when these kids have these low tongue postures, it causes a lot of crowding because that tongue isn't up on the roof of the mouth to create the proper U-shaped arch that we want to see, to have the symmetry, to have the alignment. And then later on in life, that can lead to other problems like continued mouth breathing, habitual mouth breathing. And that can lead to big tonsils and big adenoids and nasal obstruction, because what happens is when you continuously mouth breathe because of low tongue posture for whatever reason, that causes all the viruses and bacteria in the air that usually get filtered through our nose to be breathed directly through your mouth, which enters your tonsils right away and isn't pre-filtered. So it causes hypertrophy, it causes enlargement. And then parents come to me, and that really, even though my practice is truly like a whole body focused pediatric practice, I really see a lot of kids with like these issues, airway focused issues, because I consider myself an airway focused provider and a biological provider. And I see these kiddos come in really with these subspecialized issues that they've seen so many providers for, and nobody could tell them the root cause as to why. Why is this happening? Well, if you want it to stop happening and never happen again, you have to work collaboratively at that root cause. Because I see kids like they're later on in life, 11, 12, 13 years old, with like very poor sleep, not doing well in school, having all these troubles, enlarged tonsils, enlarged adenoids, got them treated from ENTs. Yeah. And some of it came back.
Wow.
Because it can. And nobody explains that to them. And they're like, what's going on? And I'm like, hey, did you ever have issues with feeding in birth? After birth, how was your breastfeeding journey? Did you choose to breastfeed? How was it?
Let's go back to the beginning.
Yeah, and then we go full circle and we see this was undiagnosed for whatever reason. And truly, I do believe that you are the master at your craft. So I don't think a provider should like overdiagnose or underdiagnose, but I do believe in like pulling from your community and getting that, like you said, giving people the opportunity to get the services they need if we have concerns. So I don't think there's no malice behind it. I think they just didn't know. These providers didn't know.
Yeah, absolutely.
And then it caused this child to go undiagnosed, and it caused all these issues. And of course, things get better. This is all treatable. But it's important to know as to why this is happening.
Yeah. And very few people talk about the actual birth. When you look at a child and you see something, can you almost always directly link it to, oh, this baby was vacuum born, or this baby had a long push, or this baby was OP. The babies that come out sunny side up are going to have a whole different experience that we call them the babies who read the manual and tucked their chin in and flexed their head and came out flexophalic, right, with their head down.
It's a great way to fit it.
Are you seeing any changes or anything coming out at you specifically?
So I have my own first kid.
Yeah.
Yeah, he's 5 now.
He's a big boy.
And he was born beautifully. APGAR scores off the charts. Perfect. I pushed for like a minute. Not even. Nice. I pushed 3 pushes. The baby came out.
Wow.
The birth was hard. The actual experience of the birth. I had my first baby during COVID. Mm-hmm. My mom actually is a midwife, but she doesn't practice. So I wanted her there, but she couldn't be there. I want
your mom on the podcast.
I wanted to have a home birth, but my husband has a lot of trauma around birth and delivery as he's a physician and didn't feel comfortable for our first baby for whatever reason. Yeah. And my mom was fun. So I really wanted her there. She wasn't there. So I really didn't have anybody to like speak for me. Mm-hmm. They wanted me to labor with a mask, like an N95, and I didn't. But my husband wore a mask, and it was just very unusual. And I thought, I know it all. I'm like, I've been seeing babies for years. I am a provider. I think I know how to do this. So I went into the hospital, and it was just so unusual. They gave me an epidural, and I had a weird reaction. And my body went into frigid phase, and I started shivering and shaking, and I was itching everywhere, and it was the fentanyl. I didn't know that there was fentanyl in my epidural.
Oh, yeah.
And
cousins with morphine.
Yeah, and the nurse got into a fight with my anesthesiologist, anesthesiology resident, and she said, I told the anesthesiology resident, I said, please, this is not normal. The nurse kept telling me it's normal. I don't feel like this is normal. Help me. Don't just cut off the meds. I'll be fine. Just like fix it, because I don't feel comfortable at all. And she was like, okay, don't worry. I'll switch it to a different medication. And the nurse came in, and she got mad at the anesthesiology resident, got into a fight with her in front of me and said, you're not supposed to do that. I'm going to go tell your attending this and this and that. And I've been there. I've been a resident, so it's just so disheartening to see I felt for that anesthesiologist because she was just trying to hear me out and help me. And the nurse was pulling like a hierarchy card, and it was just it was like not a good feeling watching
and not in labor, and not when you're in labor and you're not feeling good.
And then I pulled the anesthesiology resident aside, and I said, like, I know this is like not your typical day, and this is not good for you, but can you just like make things harmonious between you and your colleague, because I just want to have like a great delivery, a great birth. And
Oof, I'm getting tense just hearing about it.
And it was just like those stories you hear, and the baby came into the world, and that my first kid came into the world tense. Even though he came in the perfect textbook, read the manual, everything was great, he came into that world tense. And I'll tell you, he was it was very hard to come into motherhood having that experience. I put the baby on, he latched, it was wonderful in that golden hour. He latched, and then it was excruciating pain. I was like, ow, what's going on? And then the nurse came in, and she said, oh, this is normal, it's fine. Put him on the other breast. Oh, this is normal, don't worry, you're good. OB said you're good. And I looked in the mouth after I'm like, oh, my baby has a tongue tie. I can't believe it's also happening to me.
To you, yeah.
My baby has a lip and a tongue tie.
Yeah. And you're being told everything's okay because the birth was beautiful, the APGARs were good.
And they don't know who I am or what I do for a living. They think that I'm like just overanalyzing. I explained to them, I said, this is a tongue tie. Yeah. And as soon as my epidural wore off, I got out of the hospital. I had like less than 24 hours in the hospital and left. And
get me out of here.
And I went and we treated it. And I was lucky, but my nipples were bleeding. I wasn't even able to have colostrum. I had to formula feed right away.
Yeah.
It was so painful.
Yeah, the baby's going to
And it had to heal. And we treated it right away. Immediately, as soon as I brought baby back to breast, it was better. Everything felt fine. I wasn't able to fully breastfeed because I had other issues like IGT and things like that, maybe 2 ounces a day total of breastfeeding. But I didn't care because I still wanted to have that experience. But at the same time, I often think, and this baby, keep in mind, the conversation you were saying earlier about like the babies that cry out all the time, no matter what, after that treatment, it didn't make a difference that my first child would cry every single day, every hour on the hour, endless minutes, endless. And I would bounce the baby, hold the baby, walk the baby. It was like typical that my child was crying from 2 to 6 a.m. every night. It took up to five to 6 months until that baby got to normal. And I never figured it out. I went to GIs, I did this, I did that, I did it all. And I really just think it was like the process of the delivery. Maybe I'm completely wrong, but I did craniosacral therapy, chiro. Yeah. That tension, he carried it.
1,000,000%.
And I saw a baby yesterday, actually, very similarly. And I honestly started crying because it reminded me of what I went through. And I swear, I feel like you've seen it, and you'll never really know because you hear about colicky babies, but unless you've really lived through it, you will not know how traumatizing it is to a mother.
It took me, I wanted to like drive away.
Yeah.
I'm sorry for that experience.
Okay.
And I see the tears in your eyes just talking
really
about it. And
it's
really
been
hard. 5
years.
It's
very triggering.
Oh, absolutely.
Yeah, it's extremely triggering.
It's so interesting. We talk about this on the podcast a lot. My oldest is 32, so I have 33 years of now looking back at that experience. And my baby, and I've talked about it a lot, the nurse wouldn't let me push because there was no doctor in the room. So literally held her inside of me for minutes until the baby sort of pushed back and was born. There was no doctor in the room and everything was fine. But my daughter did not stop crying for about 4 months.
Yeah.
Just cried and cried and cried. And I always joke, like to this day, she always feels like someone's pushing back at her. Even if you're not pushing back at her, she feels like you're pushing at her. Mm-hmm. So, and I think that just came from that day and the trauma that I went through being completely unmedicated, 19, and someone literally holding a baby inside of me and saying, don't push. It was like what World War II torture was made of. So I think those babies, to your point, they pick up on that.
Yeah.
And she has a huge migraine history too, like all sorts of neck and sort of scap and trap tension that lead to migraines. And I really believe inherently as her mom that it happened that day. And I didn't have the tools. Like I didn't know. I really, and I always say I wanted a baby so bad, but when the baby came, I wanted to drive away. Like just nobody told me about this. You guys keep saying it's normal. It is not normal.
Yeah.
I don't feel good. And it took a long time. And it was actually stopping breastfeeding that set me free. I finally was able to be like, we're going to formula feed and this is what's going to happen.
Yeah.
And then I think my calming down calmed her down.
Yeah.
But to your point, these babies are listening. They are feeling, they are hearing the things that we say. I'm very, very sensitive as a midwife to the things we say about babies. You know, even the baby that's born and we're like, oh, you naughty baby, you were breech, or oh, you naughty baby, you made your mom be in labor for 4 days, or oh, you chunky monkey, or, you know, the things we say, those babies are internalizing from the get-go, right? So I try that when they come out, first I always say a little prayer when their head comes out. And then I welcome them and I'm like, you're the best thing that ever happened. Thank you for coming. And then I sing them happy birthday.
Yeah.
Because all of us in the room, we affect that early imprint of tension. So you experiencing that tension, first you weren't feeling good.
Yeah.
Number one, you were having some sort of reaction. What was the antidote, by the way, to the epidural?
What they changed it to bupivacaine.
Okay. So you had a reaction to
the fentanyl.
So they waited for the fentanyl to go down, or they discontinued it and upped the bupivacaine, which probably made you a lot more numb, but took the itch away. So fentanyl is morphine's cousin, so it can make people itch and feel really yucky.
Yeah, I had no idea.
I'm sorry that happened to you.
It's so important to get educated. All moms should get get some education.
1,000,000%.
When they're
and
pregnant.
a doula, hopefully.
Yeah.
And a doula,
Yeah,
even
and a
though
doula.
you're a dentist and your husband is a physician.
I think it's like great.
We just had an OB with a home birth. She was like, I work in a hospital. I'm not having my baby in a hospital. She's an OB having a home birth.
Amazing.
So the education, the holding, the options, it's really everything. Thank you for sharing that story.
Yeah. Thank you for listening.
Yeah, and I will listen to birth stories all day long. I think that everyone needs a chance to debrief that for sure.
We were able to redeem it with the second.
Right?
Okay.
Yeah. I redeemed it with the second, with the nurse delivering again and the doctor not coming again. And it was the best thing that happened. The nurse was delightful. She caught my baby and we were good. It was great. So the redemption babies, right?
Yeah.
So I'm assuming once in a while someone diagnoses a lip or tongue tie. They come to you and you say, it's okay, we don't need to revise it. In what situation would you say that? Or does that ever happen?
Everybody has some sort of attachment. A frenulum that attaches the tongue to the floor of the mouth, or the lip to the alveolus, which is where the gum tissue is, or the cheek areas. We all have some sort of attachment there. It's just when it's deeply restrictive, or if it's inflexible, or when it causes functional related issues in which we treat. So sometimes, like yesterday, I had a baby that came in. They were clicking issues, difficulty, and difficulty feeding, very, very long feeds. Totally functional in the mouth. But we were able to give them tips and give them information about how to strengthen the muscles of the tongue, lips, jaws, and cheeks to help them improve feeding, but also people that can support them as well. And also some conversations about fascia tension and how that can impact the baby too. So it's like you said, it's multifaceted.
Yeah.
There's different approaches to treatment. But when it comes to like, when they are restrictive, sometimes treatment is necessary in order to help the baby along the way, or the toddler, whoever I'm treating. And that treatment can mean treating the same day I see them, or it can mean that we have to do something prior, some work prior before I treat them, meaning doing some oral play exercises, working with the oral motor therapist or body worker prior, because it will optimize the result. So we start with a consultation, talking about the options, explaining what the treatment would be like, and then moving into the next steps whenever they feel ready. I would say the procedure in and of itself is in office, awake. In my practice, parents are welcome to be in the room if they want to be. If they don't want to be, they don't have to be. I have multiple assistants there helping the baby, and we do allow the baby to have the option of having a topical anesthetic prior. And that's a topical lidocaine that we place directly onto the areas in which we're treating.
Kind of like an Oragel sort of thing?
Oh, no, not Oragel, because it has benzocaine. I use 2.5% lidocaine tetracaine mixture, and then we place it directly over the areas that we're treating. And then I use a laser to release it.
Okay.
And the reason I use a laser is because I've found that when I use a laser, it's not only more precise and effective, it's also a decreased chance of bleeding, and it's more comfortable for the baby.
Because it cauterizes as it cuts.
Yes, and it heals better overall.
Interesting.
Yeah,
so were you trained to cut with scissors or no?
So I have a very interesting history. So I learned in residency how to do this treatment with scissors and sutures, but I also learned through a laser. And then at the time I was learning this treatment, I also met my husband, Dr. Zaghi, who's an ear, nose, and throat and sleep surgeon. And he created this technique on how to do tongue and lip tie treatments called functional frenuloplasty. He trains thousands of doctors all around the world every year on how to do this treatment.
Wow.
So he worked with me. I worked with him. I learned from him. And then after my residency, we got married. But essentially,
what a great match.
Yeah, I was learning through him, and we've shared many interests. Yeah. In this field.
That. So you talk about residency. I always associate residency with MD.
Oh, yeah.
Not with DDS. So talk to me about dentistry residency.
So there's a residency that you have an option to do if you want to be a specialist.
Got it.
For all fields in specialties.
Got it. So you went into pediatrics.
I went into pediatrics.
Someone else could go into orthodontists or
whatever they're interested in.
I see. Okay, I love that. See,
That's cool.
I learn all the time with my guests. My favorite part of my job. So what's the recovery?
I would say the recovery ranges in terms of time. Usually the child is fully healed by the second week.
Okay.
But we continue these exercises that we prescribe to them up until 6 weeks.
Okay.
And I would say the discomfort ranges. Sometimes it's usually it's like I see the most discomfort the first day, if there is any. Sometimes babies bounce back really quickly and they don't have much discomfort. Sometimes it can last about 3 to 5 days of discomfort.
So if someone has a severe lip tie or a severe tongue tie, is the depth of the cut going to be more, thus the baby's going to heal harder? What's
That's a
the
good
healing?
question. I noticed that the babies with the more severe ties do have a little bit of a harder healing process.
Got it.
Meanwhile, there's no evidence to support that. That's just something, it's expert opinion.
Right, right. And anecdotal from the parents, right?
Yeah, of course. What they say.
Yeah, what they're
Exactly.
saying. Is there anything that could go wrong? What are some complications to it?
Yeah, complications can vary. Sometimes bleeding can occur. But the most common things that can happen include bleeding. And that's why your doctor should be well trained on how to handle that and what to handle it with.
Bleeding that happens right away.
Yeah.
Okay.
And then also post-operatively, there could be bleeding. So you have to sometimes talk to the parents about what to expect, but the provider should know if that might happen in that case.
Yeah.
In my opinion, lasers really help to prevent that from happening. And then thereafter, reattachment can occur. And reattachment meaning that the tissue can come back, but restrictive or just as restrictive as where they started. That's why it's really important to see the babies. I see the babies.
Follow up.
Yeah, twice at least, to make sure everything's going okay. And that's very important, I think, and making sure they understand the aftercare and how to perform the aftercare, especially when they're tired.
Yeah.
Sometimes it can
and
be
the
really hard.
aftercare is obviously post-op instructions. Do the babies need Tylenol or any sort of pain management or arnica? Or
Arnica's is one of my choices.
Okay.
There's other homeopathic.
Like sublingual?
So what I do is I ask them to consider some pellets and place it directly in the breast milk and let it dissolve or crush it.
Yeah.
And then from there, deliver 2 to 4 drops through a syringe if needed.
I love that.
And then also there's camellia and other things. And then you can consider giving acetaminophen if it's absolutely necessary. But I try to put it as a last resort type of thing. Yeah. I would say not many patients need it.
And they can start breastfeeding, bottle feeding, whatever
Right
they
away.
need to do right away.
Yeah, as long as sometimes the baby's a little numb. So you just have to kind of see.
Just takes a second.
Yeah.
After
And
you get a
sometimes it
cavity
takes
up there,
coordination treatment too, just recoordinating and getting them back on sometimes. But it really depends on the baby.
And how soon after the procedure do you start the massage and the exercises?
6 to 8 hours.
Wow, so soon. And then do you refer to OT from there or?
It depends. Sometimes they're already working with somebody. Yeah.
Wow. Okay. And you have a lactation consultant in the office?
I don't.
You refer out? So I'm assuming you refer out to someone who's monitoring the growth of the baby and the feeding and the transfer of milk.
Normally they come with their lactation consultant already working with them.
Okay.
So that's very helpful and I think very important so that they can have the support, especially post-operatively, to get them back.
And what's the latest someone can have their tongue or lip tie revised?
Elderly people even do it. It just depends because later on, sometimes we see these people with low tongue posture that have developed issues with mouth breathing or even TMJ related issues due to the tension.
Yeah, or swallowing as they
grinding,
get older.
swallowing. So, I mean, not always is it diagnosed early on in life. So sometimes it's treated later.
So it's really never too late to do it. I'm assuming the healing on adult is going to take longer than on a baby.
I think I don't treat anybody over the age of 2 for tongue and lip ties. I refer them to my husband.
Okay.
My husband treats all the children 2.5 and up. I'm under the umbrella of the Breathe Institute. So he has his institute in the same building as mine, but a different suite. And we collaborate a lot with each other.
I love that. So
I don't get to see the differences between.
That is such a beautiful thing. I love that. I love that you guys have that.
Yeah, we're lucky.
Why does a baby need to see a dentist and how soon? I mean, I always had this belief of teeth fall out, you have a second set. Why does a 1.5-year-old need a dental cleaning?
I think the most important thing is developing that relationship and getting the skills to understanding how to maintain good oral hygiene for their lifetime is the most important thing. Prevention. Prevention is key. It's crucial. And spending that time with the dentist to develop that relationship decreases so much anxiety for the child, but also for the parent. Because I see patients, yesterday I had a mom that had so much anxiety bringing her child in for the cleaning for a toddler because she's like, my kid's going to act up and he's going to run around. He's not going to do it. I'm like, hey, let's give the kid the chance. We shouldn't push off the appointment or push off the experience for the child or the ability to gain that knowledge just because We think they won't do it. And honestly, they all do. They do great.
Yeah, I took my kids to the dentist literally every 6 months from when they were really little, to the extent that our pediatric dentist was like, if you're ever not at the appointment, I'm going to think something really bad happened to you, because we can like time our 6 months by your visit.
Yeah.
I was very, very good with that. What are some potential dangers of poor oral hygiene in pregnancy?
So the thing is, in pregnancy, sometimes people have a lot of nausea and vomiting, and that can lead to a lot of tooth decay in and of itself. And we all notice that when you're pregnant, your ligaments are a little bit looser. So things shift a little bit easier, which makes it a little bit easier to get tooth decay and makes it very easy to get changes in crowding, etc. too. Add poor oral hygiene on top of it. That's just a recipe for things not going well for postpartum or during the pregnancy. So I think it's really important, if you're pregnant, if you're listening, try to see your dentist when you're trying, because you should get a really good cleaning and a checkup on everything. Get all your x-rays before if possible. If you can't, you can't. And then get your cleanings every 2 to 3 months. And I think that's
during the pregnancy.
Yeah, I think it's just crucial just to make sure everything's on track and everything's okay, especially if you're that mom that has the vomiting and the nausea. Just like make sure you're okay.
Because there's a pH balance that's going to happen in the mouth with the vomit that's acidic too. It's going to change.
Yeah, it causes an imbalance, and that can lead to a shift in the oral microbiome and lead to tooth decay and all sorts of periodontal disease and all sorts of things that it's just not a good recipe. Yeah. It's interesting, like when these parents have the nausea and the vomiting and difficulty with like their prenatal vitamins or good nutrition in pregnancy, those are the kiddos I really want to see early, because that we notice that it can cause the teeth coming in a little bit more fragile, a little bit weaker, and we have to really track these kiddos.
2 more questions. Number 1, can you debunk any pacifier and bottle myths?
Oh, good question.
Please.
Honestly, great question. Pacifiers and bottles that market themselves as orthodontic cause issues. And those are the biggest with the oral development. And those are the issues that I see the most with kids as they're developing, with things called open bites, where when you smile, you see like a big opening between the teeth, because they've developed this low tongue posture from the habit of being on these pacifiers and bottles often. And it really is dependent, honestly, on how often they're having these things. So we talk about duration, intensity, and frequency. Those are the 3 most important things. So
sounds like contractions.
Yeah, that's interesting. So like if you're on the pacifier all the time, it's going to cause issues most likely compared to a child that's only on the pacifier soothing and removing. So there are a couple pacifiers I like. Those with the rounded tips I prefer. Those that are flat and bulbous I don't prefer. And I try to ask parents, consider starting to wean at 4 to 6 months of age. And if you can't, because for whatever reason the child really needs it and your mental health is important, don't stress, but try to decrease it to the point where it's just as needed for naps and as needed for bedtime. And then go a little bit slowly towards weaning off closer to the 1-year mark if you can. If they're still on it at toddlerhood, start working on a plan to decreasing it. And when it comes to bottles, I know they do say, let's try to get off the bottle between age 1 to 1.5, right, because it causes a bottle mouth. But the most important thing that's not a myth is that being on a bottle a lot can cause tooth decay, and that's called baby bottle syndrome. Right. This is a habit that has happened like in the past, and it's kind of continued over time.
Leaving the bottle in the baby's mouth for the kid to fall asleep.
Exactly. But we got to make an effort to kind of break it up, that when they come, especially when they start getting teeth, or when they're eating solids is usually when they start getting teeth, we want to start brushing their teeth as soon as the first tooth comes in. And that is after the last bottle or breastfeed, and not before, because it's important to clean the teeth before going to sleep.
Right.
Yeah. And I think,
which is hard, because that's the time when kids fall asleep, and who wants to then take them to the toothbrush? It's hard.
And not all the babies are going to get cavities, but some do. And it's just important for us to like conversate about like what to do. And if it's really hard and you can't break the habit and the kid wakes up a lot throughout the night, at least have a wet washcloth or something around to wipe the teeth as much as you can.
To wipe the teeth down. Yeah. I remember there was a trend a while ago when my kids were very little to give your kids a little bit of water. Obviously not the breastfed little tiny babies, but to give the kids a little bit of water after the bottle.
That's great. And I know there's various ways of doing that. Okay. So that's something to consider.
And is the sippy cup as detrimental as the bottle?
So we don't recommend sippy cups. We recommend transitioning to straw cups after the bottle.
Oh.
Yeah.
Look at me. I didn't know that.
Yeah. So it's just because
I don't see the babies then, y'all.
Yeah.
They're already big.
Yeah, just because and this is just something we've learned over time through speech therapists that focus in oral motor therapy that have taught us that it's more beneficial for these kiddos to have transition into straw cups for speech development or open cups for speech development compared to sippy cups.
To sippy cups.
Because of like the tongue posture, etc. And this is something I learned. I'm not an expert in it.
Tongue posture is everything, huh?
Far from an expert in these things, but I've taken some courses and I've learned along the way through my colleagues, and I'm really grateful for the knowledge. Yeah.
We all teach each other, right? So much we can learn from LCs and from educators and from physicians and dentists. Lastly, can you, I don't know if you can talk a little bit to MTHFR and midline and define it for me, for my listeners.
So MTHFR gene mutation is met tetrahydrofolate reductase deficiency.
Yep.
So I actually have it.
Me too.
I'm homozygous for one copy, heterozygous for another.
Yeah.
And it's just so interesting to see how much I didn't know and how it affected me.
Oh, yeah.
I remember being in school and I was tired all the time, and I would take B complex with the wrong type of B vitamins. Yeah. I was taking folic acid rather than methylated folate or whatever else. And it really affected me, I would say, because it would make me feel worse. Yeah. Because of the histamine increase. So when it comes to MTHFR, there are a few things you need to know. Some people feel, and I don't really have any evidence to support it, that it can be associated with tongue tie, but it's really hard to say. I'm not sure. So I just think it's important to know that you have MTHFR gene mutation, take the right vitamins, but also check your labs every so often so you're not overtaking anything. And then also work with your dentist to know, because there are things that you can't do if you have MTHFR, like certain types of things you can't have, like nitrous oxide, which some people birth with even.
Doesn't metabolize properly with people. Yeah, we metabolize things differently for sure. So would you recommend that someone who's trying to get pregnant do an MTHFR test and see if they have it?
Yeah, I think your OBGYN is able to take a genetics lab, right? Or your midwife. You can send for labs, and you should find out about any genetic mutations you might be exposed to or have.
Right. And now we're doing the carrier screening for the guys too. If the mom comes up positive, or if one parent comes up for it, we test the other parent to make sure they don't both have it.
Yeah,
and then increase the baby's chances of having it even more. I have so enjoyed our time together. As with all of our guests, I always say I could have you here all day and ask so many questions and learn so much from you. Yeah. Thank you for your time.
Oh, of course.
And I think there's so many subjects we could have you back to talk about. This has been fascinating.
My pleasure.
Thank you for your time.
Thanks for having me.
Thank you. Dr. Nora Zaghi.
Take care.
You'll find her in the show notes, West Los Angeles. It's been a pleasure.
Yes, my pleasure. Take care, everybody.
Thanks. Thanks for listening to the Mama Tusa podcast on the Industry Plant Podcast Network. Mama Tusa is hosted by me, Atusa Benji, and produced by Josh Stretton Carlson. Our theme music is composed by Mary Lalazarian. If you enjoyed the podcast, please consider leaving us a review and subscribing. See you next Tuesday.